Good afternoon. First of all, thank you very much for Dr. Tariq for the invitation and to join this very nice and successful meeting. I am very happy to speak about the spine problems, spine scoliosis in the neuromuscular patients. We are, as surgeons, are not good speakers as you, but we are dealing with angles and with knives. Just make measurement for the angles and go for the surgery. This is for the usual spine patients, it is effective, but really for the neuromuscular scoliosis, it is not effective because every patient is a special case, and every family also are a special case. We have to deal with the patient and family, especially to achieve the good management for this kind of deformities. So neuromuscular spine deformity, as definition of the scoliosis, is three-dimensional deformity of the spine, curvature more than 10 degrees in the coronal plane. When the patient and when the child start to achieve the head control and started to sit down and walking, he will develop four normal curvatures, two convex anteriorly, which is the lordosis, and two convex posteriorly, which is the normal kyphosis. The etiology of scoliosis, as we know, congenital scoliosis, structural scoliosis, neuromuscular scoliosis, scoliosis with another syndromes, and idiopathic scoliosis, degenerative scoliosis, and also traumatic scoliosis. The neuromuscular scoliosis can be happened with a lot of pediatric neurological problems like cerebral palsy, Duchenne muscular dystrophy, myelomeningocele, spinal muscle atrophy, Friedreich ataxia, spinal cord injury, and a lot of another neurological disorders. Curve location according to the location of the apical vertebra between cervical and lumbosacral. It makes the different in also in the type of the treatment with these patients. Scoliosis in neuromuscular disorders is very common. It's about 15 to 80% of the patient, they have neuromuscular disorders. But the adolescent idiopathic scoliosis prevalence is about 2-3% from the general population, which is very important to make checkup for all the patients they have neuromuscular disorders to find the scoliosis problem as early as we can, also to prevent the surgery. Long-term risk of progression, there is a good study of Tomets and Simon speaking about the rate of progression was about 0.8 degree every year if the curve is less than 50 degrees from the before skeletal maturity or in the time of skeletal maturity. And if the curve more than 50 degrees, it will be 1.4 degree every year. The classification of the scoliosis: infantile scoliosis 0 to 3, juvenile scoliosis 4 to 10 years, adolescent between 11 and 17, and more than 18 is the adult. The curve in the neuromuscular scoliosis is different from the other kinds of spine deformity. Here we can see double curve with good spine pelvic, oblique, normal pelvis, and thoracolumbar big curve with normal pelvis, and thoracolumbar big curve with pelvis obliquity, and also the lumbar big curve with pelvis obliquity. The scoliosis is very common in the deformity in the neuromuscular disorders, and the spine deformity usually present at a very earlier age and progress during growth rapidly, and also continue to progress also after skeletal maturity. Conservative treatment of the neuromuscular scoliosis, also as the normal scoliosis, we have to see the patient regularly, make examination, and make regular X-rays and exercises and physiotherapy, bracing, wheelchair modification, baclofen pumps, and Botox injection also have a good influence about the progression of the scoliosis. Non-operative management found some limitation. The physiotherapy and the bracing can make can delay the progression of the scoliosis, and in some kinds of patients we can postpone the surgery, but most of the patient developed also we are doing good physiotherapy, good bracing therapy. We cannot do anything, and we reach the point of the surgery, which is good for the surgeons. Breeze treatment in neuromuscular spine deformity. There is a good paper for Elefson and Al-Dabbagh shows that limitation of the curve of the progression in ambulatory patients with smaller lumbar curve, and also the use of dynamic spinal brace in the management of neuromuscular scoliosis demonstrated improvement in cup angle as well as sitting stability and caregiver satisfaction in the group of patients treated with dynamic 3-point molded braces. Overall, long-term bracing for NMC is rarely effective. Now we will go to the surgical treatment. We can see big difference between the patient position in the wheelchair before the surgery and after the surgery. And also the patient are sitting very comfortable in the wheelchair, which was not like this before the surgery. When we have to do the surgery, in the normal scoliosis patient, we are looking about the cup angle, the curvature progress before the skeletal maturity. There is very clear shame therapy. We are following it. When the curve is from 0 to 20 degree observation and follow up with X-ray, between 20 and 40 degrees physiotherapy and bracing, and after 40 degree up to 40 degree, we will go to the surgery. If in the thoracic curve more than 45 degree, it is indication for surgery. In the lumbar spine more than 40 degree, it is indication for the surgery. But in the neuromuscular patients, it's a little bit different. Most neuromuscular deformities progress greater than 40 degrees and initiate surgery before the curve will be very severe. Indication for the operation depends on every case itself and the family. The main indication for surgical treatment is progression deformity with unacceptable trunk shift of pelvis obliquity and which affects standing and sitting balance and positioning. Surgical indication also any significant curve resulting in functional disturbance and cardiorespiratory compromise, progressive spinal deformity, not controlled with braces, and painful deformities. Preoperative, we need a lot of things we have to do, from X-ray, standing X-ray if it's possible, supine X-ray, bending and tractional X-ray, and sitting X-ray, which gives a good idea about the plan for the surgery. The CT scan and MRI, sometimes very useful if we have any dysplastic spinal problems. So pediatric neuromuscular spine deformity surgeries are very complex, and because of the patient has multi-systemic involvement of the disease, the complication rate is very high, about 25%, and teamwork is very important for this kind of surgeries. Pre-op evaluation and optimization of the patient, it is very important to look about the malnutrition, cardiomyopathy, seizure problem, pulmonary problem. It is very important to consult the pulmonology, neurology, and to make a pulmonary function test when it is possible. Not all patients can do it. And if there is difficulties in the airway, we have to consult ENT, and sometimes one of the ENT should be in the operative room to help us if it's need to tracheostomy or anything else. Very important at the end to that the patient should be can healthy enough to tolerate this kind of surgery. The pulmonary function and the cardiovascular optimized enough to do this kind of surgery. The knowledge about the natural history of each patient is very important also. There is guidelines to avoid complications, as we say about cardiac pulmonology and nutrition, also pre-op anesthesia consultation, and use of tranexamic acid, antibiotics, vancomycin in bone graft. Also, it's very, very useful. And also the after surgery ICU is very important to put the patient in the ICU to continue optimizing the results of our treatment. Risk assessment, there is a lot of things we have to take care of it before the surgery. If the patient reach these points, we know that the risk will be high and we have to consider it, and we have to explain it very clearly to the families and to our staff also. The goal of the treatment is to prevent the curve from progression, to maintain the spine balance, of the coronal and sagittal planes, to provide balance and comfortable sitting position, and to reduce repositioning, and to reduce pain, and to reduce discomfortable feeling comes from the pressing the ribs on the pelvis crest of this kind of patients, and to maintain walking ability in the ambulatory patients. Complications of this kind of surgery is too high, as we say. The infection rate is too high, 5.5%. New neurological deficit also, cardiorespiratory problems, nutritional issues, prolonged ileus, constipation, fluid overload, skin breakdown, bleeding, and death. Conclusion: the neuromuscular spine deformity surgery is among of the most challenging pathologic in the spine surgery. Conservative treatment has limitation, and if the patient needs surgery, it needs really very good experience in the surgery, and it needs teamwork, not only surgeon and nurse in the operating room. It needs really teamwork before the surgery, after the surgery, and intraoperative also. The medical comorbidities for this kind of patient we have to do a lot of things before the surgery to optimize the patient for our surgery, and it will improve the results of the surgery and reduce the rate of the complications. We have some cases we can show it. 17-year-old patient with global development and quadriplegia, wheelchair dependent, cerebral palsy, scoliosis. We can see here the big curve and kyphosis and hyperlordosis. The patient cannot sit down in the wheelchair. He always sitting like this in the wheelchair, and there is no sitting balance in the wheelchair. Also, he is using customized molded wheelchair, and this is the result after the surgery. We did the spinal correction and fusion with very good sagittal balance, and the patient is sitting very comfortable in his wheelchair after the surgery. Another case, 9-year-old patient, spinal muscle atrophy type 2, wheelchair bound, and global development delay. Very big thoracolumbar curve with pulmonary compromise and hyperkyphosis, hyperlordosis. And 9-year-old, we used growing nail technique, magic rods, the name of the technique. And so we make the correction between pelvis and upper thoracic spine. And every 2-3 months, we are making elongation of the magic rods to maintain the spine and to keep to prevent the progression. And until the age of puberty, after the puberty, we can change the magic rod to put the definitive fixation. 6-year-old patient with multiple congenital anomalies, congenital Charge syndrome, multiple hemivertebra, congenital scoliosis. We can see here hemivertebra in 2 levels and hyperkyphosis in the thoracolumbar area. Here is the hemivertebra. We remove the hemivertebra, make fusion on the right side, and we put the magic rod, the growing nail on the other side to keep the spine growing and to correct it during the time. Another case, 16-year-old patient with global development delay, paraplegia, wheelchair, cerebral palsy, and neuromuscular scoliosis. This is the patient has imbalance in sitting position. We can see the curve, and this is after the surgery. We can see here good corrected spine, and he can sit down very comfortable. And this is X-ray before the surgery and after the surgery. Another case, 8-year-old patient with global development delay, quadriplegia, wheelchair, cerebral palsy, and neuromuscular scoliosis. Severe hyperkyphosis, more than 100 degree, with severe also on the coronary plan, severe scoliosis. Very nice correction with very nice sagittal plan. And it is growing nail. One is traditional and one is magic rod. We can make the elongation with a machine until the puberty age. And it make very big difference in the for the parents at home and for the nurses to deal with this kind of patient. We can see the difference between before the surgery. This is the big kyphosis, and here the ribs are on the pelvic crest. And we can see after the surgery with minimal invasive wounds correction of the kyphoscoliosis. 11-year-old patient, paraplegia, wheelchair, dependent spina bifida, cord tethering, and scoliosis. This is before surgery, 2 operations done before for the tethering. And this is the curve before. This is the patient sitting comfortable after the surgery. And also we used a growing nail to maintain the spine and to keep it growing. 16-year-old patient with congenital Methena graves, myotonia congenital, kyphoscoliosis. She has a brother passed away from the same disease, recurrent pneumonia, and chronic respiratory failure. Very smart patient. She has very severe curve from the cervico-thoracic area to the lumbar area, and very severe kyphosis and imbalance. She can walk, but she walk without any balance by walking. And this is the X-ray after the surgery. Actually, I was not happy to see this X-ray after the surgery. When you see that it is not too good correction as what the X-ray shows. But if you see the patient herself before and after, there is a big difference. And also the patient was walking very stable, and we can see here, she couldn't walk like this before. She was always like this, and she is very happy. Another case, 17-year-old patient with lumbar kyphosis, lumbar radiculopathy with claudication, Hurler syndrome, developmental delay, and another comorbidities. You can see here the hyperkyphosis And this is abdomen, this is back. We have to recognize. And this is after the surgery, very good correction of the kyphosis in the lumbar area. Here we can see the CT scan shows completely dislocation of the L5 in the spinal canal. The patient was walking like a very old man and cannot walk more than 50 meters. He has to sit down because of the compression with spondylolisthesis L4-5 and 3-4 also. And this is after correction of the kyphosis. 17-year-old patient with global development, quadriplegia, wheelchair, cerebral palsy, respiratory disorders, and intrathoracic herniation and neuromuscular scoliosis. The patient couldn't sit down in his wheelchair, and they did for him a molded wheelchair, and also it was very difficult. The family decided at the end. Also, we have a lot of risk things with this patient. They decided to do the surgery, and this is the result with very good correction. We can see here double curve, severe curves, and hyperkyphosis. And this is after the surgery. It is very long, big surgery, but the patient after the surgery, the family are very happy. He's sitting in his wheelchair, very comfortable. It makes big difference for the family of the patient and also for the patient himself. 10-year-old patient, this is idiopathic scoliosis. This is very rare case. I didn't saw like this patient before, only here. 11-year-old patient with arthrogryposis, multiplex congenital muscular dystrophy, myopathy, neuromuscular scoliosis, syringomelia, asthma. And this is the patient before the surgery. And this is after the surgery. It was very difficult to put the patient in the position during the surgery because the shoulders coming, shoulder blade coming together, and it was very difficult to make the surgical incision here. But very good correction after the surgery. And this is the X-ray before and after with growing nail also to maintain the spine growth. Okay. So this is another neuromuscular scoliosis patient. Also, we can see the result after the surgery. Big curve. This is also with brace, with vagal bump also, and very good correction after the surgery. Thank you very much.